Again, and thank you for making the effort to come so early. I know it was President's dinner, so it must be really tricky for all of you to be there this morning. And I want to also thank the organizers for inviting me to speak on a topic that I feel really passionate about. As per usual, I'd like to declare my conflict of interests, which commonly include academic lectures like this. I think talking about cow's milk allergy, it's first of all important for us to discuss the prevalence. The most commonly quoted paper is the Europreval study, which included a big cohort of 12,000 infants from all over Europe, which were followed up between 24 and 30 months. And these were children that had a blinded challenge to cow's milk, and they found an overall prevalence of 0.95% with a variation between 0 and 1.3%. Now focus a little bit on the graph. So the first thing I want to explain, total cow's milk allergies in the blue chart and IgE mediated is in the gray. So that means what is in between is therefore non-IgE mediated allergy. And here we can already see the challenge of the diagnosis. On the one hand, Greece has got 0 cow's milk protein allergy. And on the other side, Lithuania does not see any children with non-IgE mediated allergy, versus the UK that has got 50% of the children with cow's milk allergy, in fact, have a non-IgE mediated allergy. Two of our colleagues, Koletsko and Heine, already highlighted the concern around the poor recognition, in particular of non-IgE mediated allergy within this birth cohort. And you'll see when we're thinking about challenge-proven cow's milk allergy, there is a variation between 1.8% and up to 7.5%. So whilst, of course, we acknowledge there's variation in different countries, there is also a problem when we look at recognition. All of us know the very well-known DRUCMA guidelines, where they divide, like any of the other guidelines from Espghan, cow's milk allergy into IgE-mediated and non-IgE-mediated allergy, with IgE-mediated allergy linking to urticaria, angioedema, and anaphylaxis at the severest spectrum, and non-IgE-mediated allergy, including conditions like EOE, food protein-induced enterocolitis, or food protein-induced enteropathy. These conditions, for us as clinicians to recognize, are translated into symptoms. The symptoms broadly impact on the gastrointestinal tract, the respiratory tract, skin, and you have the more severe spectrum, which is systemic, which is anaphylaxis. If you look at the symptoms from the gastrointestinal tract, we see common symptoms like diarrhea, constipation, failure to thrive, blood in the stool, and you see, in terms of respiratory tract, you see runny nose and wheezing, chronic cough, skin, of course, from urticaria to angioedema, but also atopic eczema. And the problem that we have is that each one of these symptoms you can find in a different condition. And I know for us as clinicians, I've given you a couple of examples. For example, if a child has diarrhea, it can be viral, bacterial, can be secondary lactose intolerance, it can be early onset IBD, bloody stool, and up to 20% of infants, you find hematochezia, which spontaneously resolves. Failure to thrive is part of a differential diagnosis for a multitude of diagnoses. Similarly, when you're thinking about the respiratory tract, you think, well, a runny nose, a cough, wheezing can be an upper respiratory tract infection, whether that's viral, whether that's bacterial. And data indicates 20 to 25% of children may have eczema without any association to allergy, never mind cow's milk allergy. And this is at the moment where the challenge lies, is that all of these symptoms that are commonly seen in cow's milk allergy, each one of them can be explained by a different condition. Now, this overlap, in particular between functional gastrointestinal disorder and eczema and cow's milk allergy, has been well described A very recent paper by colleagues of mine from Imperial College and also from King's College looked at the overlap from a cohort from the EAT study. That's the early acquisition of tolerance. For those of you who do not know, it's 1,300 children that were randomized to early introduction of allergens and they were randomized from 3 months, and otherwise at 6 months WH introduction of allergens as per normal. But critically, all of these were exclusively breastfed, so both cohorts. They used only the control cohort, which is the exclusively breastfed cohort, until 6 months, and they found that if they looked at the documented vomiting from the questionnaires that parents filled in, 22% reported at least at one assessment frequent vomiting. 22% also expressed in the form at least at one assessment frequent colicky type symptoms. And then we have 43% documenting that they had eczema. But from this cohort, 13% had other symptoms related to cow's milk allergy, and only 0.7% had a challenge-proven cow's milk allergy. This should not come as a surprise to any of you, because our chair, Professor Ivan Arnhem-Plus, did a fantastic paper summarizing worldwide prevalence of documented functional gastrointestinal disorder and found very similar percentages in terms of colic, regurgitation, constipation, and diarrhea. The concern of using just symptoms as a diagnostic tool, so just applying symptoms, was highlighted by the EAT study. And those of you that were at the session, this should not be news to you. But just to remind you, 1,300 children were used, and it was a secondary analysis based on the questionnaire where they ticked symptoms that these children had. And so what they did is they used the IMAP cow's milk allergy guideline, which is a very common guideline, and that included the symptoms here on the right: persistent irritability, reflux, food refusal, diarrhea, constipation, all symptoms that you'll find in any of the guidelines that cover non-IgE mediated allergy. And what they did was saying, okay, if we just used the symptoms and ticked them off and looked at how many would have had cow's milk allergy based on the symptoms only, they found that 3 in 4 of these infants would have 2 or more mild to moderate IMAP or non-IgE mediated symptoms, and 1 in 11 would have had severe classified as severe. So this paper very much went to, oh my goodness, we are overdiagnosing. I am an author of IMAP, and I can tell you many of you are authors of guidelines, Espghan, DRACMA guidelines. None of the guidelines recommend just using symptoms and ticking them off and saying, there you go, that's your diagnosis. No, we say we use an allergy-focused history, and symptoms just create awareness. It's part of your differential diagnosis, and then you move on and perform allergy tests. And this is where the challenge in particular lies with non-IgE mediated allergy. You don't only have overlapping symptoms, but it may take days for the symptoms to appear. You might have, in a child that is on solid foods, multiple foods that are introduced over 1, 2, or 3 days, and so you have to think about 5 or 6 different foods as possible culprit foods. And outside of EOE, we do not have a reliable test to indicate whether it's a non-IgE mediated and support your diagnosis. Your diagnostic procedure is the elimination and the reintroduction, and we see problems with that as well, because either a lot of times the reintroduction does not occur because of poor follow-up, or we have parents, I have lots of parents who refuse to actually re-challenge because the symptoms were so horrendous. So you have this challenge, and you have the concern about overdiagnosis, but then there is the concern about delay in diagnosis. And the data, in particular in the UK, where the concern about overdiagnosis is highlighted, we have also data that we are underdiagnosing it, and there's a long delay in from the presentation of symptoms until the diagnosis. In fact, it takes 2 to 6 GP visits with symptoms and almost 2.5 months before they are started on the right treatment. This delay in diagnosis does not go without consequences. For the child, it increases a risk for faltering growth, increases the risk for feeding difficulties, for vitamin and mineral deficiencies. These children are in pain, they don't sleep, the quality of life for parents are affected, and it can also have a detrimental effect on the healthcare system. Most of us, when we think in non-breastfed infants, we think about the cost of these feeds only. We forget about the cost to the healthcare system, which is this child comes again and again and again for an appointment. We get prescriptions inappropriately, sometimes of PPIs, of all kinds of other medication. Many of my patients that come to me had 4 or 5 different feed changes by the time they're on the right feed. Who considers that as a health economic burden as well? So there is this balance between underdiagnosis and overdiagnosis that we as healthcare professionals need to get right. In 2015, we wanted to establish in a survey, do the GPs, who for us, the general practitioners, are the first port of call, do they know about guidelines? Because in theory, all of us write these guidelines to increase the awareness, to help the diagnosis. So we surveyed these GPs, and we looked also at parents, but I'm focusing on the GPs. And if you look at that, we asked them, do you know about the NICE guidelines, which are the most common guideline group within the UK? They're cow's milk guidelines, or the MAP guidelines that we spoke, or the Espghan guidelines. And you find that the vast majority were not aware of this. Many of them knew about them, but said to us, we didn't read them. And then you have a small percentage that said, oh, yes, we follow a guideline. And in particular, when we asked this group, we were aware of them, but we didn't read them. They said to us, look, we are a general practitioner. We get so many guidelines. We get so much to read, and the guidelines are long, it's confusing, so that's why we don't read them. So somehow, we as healthcare professionals need to come up with ways to increase the awareness, to provide tools to help our physicians, our dietitians, our nurses, to create the awareness of saying, could this be cow's milk allergy? There was a systematic review in 2020 looking exactly at that and saying, are there any symptom scores to inform the triage for cow's milk allergy? They found 2. One is the CoMiSS awareness tool, which you'll hear more about, and then also Gibbons in 2012 published a symptom score specifically for non-IgE mediated allergy. The latter score, after that, there are no further diagnoses, so that is not a score that is very available. But CoMiSS, on the other hand, is widely available and has been developed initially for a study, a multi-center study, but then the recognition came that, hang on a minute, this may be quite useful to increase awareness amongst healthcare professionals as a very simple symptom awareness tool. And since then, a huge amount of studies have gone in. We'll hear 2 colleagues talking about that today. But it's not only that we've had 25 original papers, but it's also been used in many countries, and many validation studies have occurred. This is how the score looks, very simple. I'm not going to talk about it because the exciting news will be shared by my colleagues in terms of how things have changed, how the validation have informed us. So in conclusion, cow's milk allergy is one of the most common food allergies worldwide. The diagnosis remains challenging, and I think none of us would say it's an easy diagnosis because we know all of the symptoms can overlap with another diagnosis. So when you have a subset of diagnoses, it's up to us not just to apply the symptoms, but to be aware of it and then decide based on an allergy-focused history, based on your skin prick test, IgE, if applicable, or any other investigations, based on your assessment of dietary intake and reactions, could this be a cow's milk allergy or not? I hope I've also shown you today not diagnosing cow's milk allergy has negative impact, and overdiagnosing cow's milk allergy, of course, has a negative impact as well. A diagnostic tool in terms of raising awareness, we are not saying it takes your practice away, it raises awareness, could this be cow's milk allergy, may really be helpful in terms of forming part of that puzzle to improve your clinical assessment. The CoMiSS score has been developed by a group of specialists who all work in cow's milk allergy, and it has been validated in numerous studies. And I hope you'll hear today how this tool has been further assessed and how the journey that us as a group have taken to really improve and evolve in regards to providing something that may be useful for clinicians. Thank you very much.